Are you prepared for a terrifying tale that involves death, terrifying living beings, and tongues? If so, continue watching. The most terrifying aspect of working as an anesthesiologist is depriving a patient of their ability to breathe on their own. Things go from bad to very, very bad if they can't breathe and you can't breathe for them either. If this happens, bad things will happen. In a general anesthetic, which is the type of anesthetic that is used the most frequently, the process begins with the administration of 3 drugs in rapid succession. First, a drug that induces sleep, most commonly, propofol or etomidate. Second, a medication used to treat the high blood pressure and rapid heart rate caused by having a breathing tube inserted into your windpipe. Third, a narcotic is a drug that paralyzes your muscles so that your anesthesiologist can tilt your head, extend your neck, and use a laryngoscope to see the vocal cords and insert the tube. Most commonly, rocuronium, vecuronium, or succinylcholine. The patient stops breathing after receiving these medications. In reality, the patient is unable to breathe. Most people may be ventilated by wearing a face mask and blowing air into their lungs for a minute or two until the medications take effect. However, occasionally, mask ventilation is not feasible. The breathing tube is inserted into the trachea to treat this. Intubation is not always feasible. The feared can't intubate/can't ventilate predicament has arrived. This is the dread alluded to at the beginning of the response. Every specialty has its own perfect storm that leads to death scenario, which keeps them up at night. This is an anesthesiologist's worst nightmare. The idea is to identify those with poor airways before putting them to sleep. Dr. Mallampati steps in. Seshagiri Rao Mallampati developed a score system, published in 1985, that enabled anesthesiologists to anticipate which patients would be difficult to intubate based on a basic airway examination. He performed his examination and then documented how difficult it was to insert a breathing tube. He began with 3 categories and then expanded to 4. To do an airway check, have the patient sit in front of you, gently lean their heads back, and put out their tongue. Children are inherently talented in this area. With that said, the Mallampati score identifies patients at risk for difficult intubation based on the structure of their oropharynx. This score is based on a 1 to 4 scale with the following criteria. Class 1, soft palate, uvula, fauces, pillars visible. Class 2, soft palate, major part of uvula, fauces visible. Class 3, soft palate, base of uvula visible. Class 4, only the hard palate is visible. It should be noted that this is simply one component of the overall airway examination. Other airway components that are often investigated include as follows: the measurement between the thyroid cartilage and the chin, thyrometal distance. Neck flexion and extension are both possible. Tracheal placement examination of loose dentition. Some individuals may ask if you can bite your upper lip to test how far your mandible can stretch. If you want to be a skilled anesthesiologist, you should aim to put your patients to sleep as few times as possible before handing them over to the surgeon. If at all possible, avoid an airway disaster by gazing into the open mouth of a patient with their tongue extended. So, here's a question: does this discipline of medicine just cure negative side effects? Please share your ideas in the comments section and remember to like and subscribe.